So we came up with this title, What's the Deal with Blood Cancers, because we get a lot of questions about why things are so different in hematology. Why is it so challenging to reach these patients as a palliative care specialist? Why don't we get called as often to see patients with blood cancers? And that really is what our presentation focuses on, trying to demystify what's different about these diseases and why that calls for a unique and targeted kind of an approach.
So one of the things, particularly from the clinical aspect, that's different is that the current model for how we integrate palliative care for patients with cancer is really a consultative focus, where we oftentimes are brought in at, unfortunately, sometimes late stages of people's illnesses. And there's a much bigger push right now, particularly through American Society of Clinical Oncology, for us to be involved much earlier. And that actually happens a lot less for patients with hematologic malignancies and blood cancers. And so one of the big discussion points here is how we do this differently, that this is a longitudinal care need where you meet people much earlier in their disease course and start to design therapeutic interventions that meet patients' coping needs around symptoms, and really working collaboratively a lot earlier.
Yeah, this is a piece that probably speaks to our title again of what's the deal. And these diseases are fundamentally different than even other kinds of cancers. So for example, if a person is diagnosed with a widespread solid organ tumor, usually that's a situation where we know from diagnosis that it can't be cured. And that's certainly difficult, and there are decisions to make around whether to do chemotherapies or other treatments that are palliative in their intent. In other words, they might help with symptoms or promote longevity, but they're not going to fix the disease. With blood cancers, we often face situations where we might actually be able to cure the patient, but the curative treatment doesn't work in all cases, and we don't really know if that person's going to benefit or not. And the toxicity of those treatments is tremendous. So a patient with an acute leukemia, for example, who's getting really high-dose chemotherapy and spending a month in the hospital and having all sorts of complications, has a 8 or 12% chance of dying during that first 60 days because of the treatment, and yet they might actually have a greater chance than that of being cured by that same treatment that could even shorten their life. So it's just a fundamentally different and even more difficult kind of a scenario and series of discussions that have to happen between the patient and the clinicians and the family around what you do and what the goals are, and so much more uncertainty about what the outcomes are likely to be. And that has unfortunately resulted in a very aggressive treatment path as the default, which often is appropriate and goal concordant, but it happens at the exclusion of palliative care integration, since hematologists tend to think of palliative care as just being about death and dying and end of life and hospice. And that's really a lot of what Jason has helped so much with, in being the person seeing these patients earlier and as a routine part of practice on this study. It doesn't matter what their prognosis is. We're all hoping and cheering them along. Hopefully they will be cured. If they're not, he's still there, he knows them, and can help us with all these other issues regardless of the outcome. And that's what we think is probably the right model for hematology.
I think one of the really exciting parts of this is that the research that Tom and Arij and others are doing of integrating palliative care upstream and earlier is the fact that this is, as Tom has mentioned, really hasn't been done. We culturally in palliative care and oncology haven't really worked together early. So the outcomes of these trials and the work that we're doing clinically in the trial may and hopefully will change fundamentally the way that we provide care to patients with blood cancers. And I think that's the prospect of this, that there aren't a lot of things I think that we do that may change treatment paradigms. And this would be a really fantastic way to improve the quality of life and hopefully outcomes for patients with very serious cancers.
So in terms of important takeaways, first, it's really important to recognize that there is unfortunately rather overwhelming data showing that end-of-life care quality is rather poor in hematologic malignancy patients. And there are many reasons why this may be the case, but we know, for example, that patients with blood cancers are far more likely to die in the hospital rather than at home, which generally is the preferred place of death for most people in the U.S. They're more likely to spend time in a hospital, in an ICU, and to receive chemotherapy at or near the end of life. And they're less likely than solid tumor patients to utilize hospice care at all, or to ever receive specialist palliative care, such as through a consult or in the clinic. So there's a lot of room for improvement. We have to start off by recognizing the overwhelming evidence that there really is a problem. Related to this, we also have to be open and intellectually curious about learning what's different about these diseases. So the idea that palliative care is a one-size-fits-all, and that if we can just be excellent communicators and attend to a person's needs as a person, then it doesn't matter what disease they have, we can provide excellent palliative care. That probably is no longer true in the era of very sophisticated early integration, at least in the cancer care setting. And I would venture that other settings like cardiovascular disease with ventricular assist devices and transplant, those are very subspecialized and completely different too. I don't know or understand much about those things. Similarly, a person needs to get to know and understand what's different about hematologic malignancies, their treatments, the associated outcomes, and how the clinicians who treat those diseases think about them and how they tend to approach them. So I hope those are a couple of key learning lessons from our presentation.
I think the second really big kind of deal with blood cancers for us clinically is how we approach integrating care longitudinally rather than sort of our old consultative model, which is really how we think about patients with blood cancers, because there is this high chance for cure, that our interventions and involvement needs to be independent of prognosis, that we're hoping for the best, we're hoping for transplant, we're hoping for cure, but that the needs that these patients have, both for coping early on for their illness, with symptom management needs longitudinally through their induction therapy, consolidation, onto transplant, new therapies that are coming online, and helping with those toxicities, which we'll be learning about going forward, and how we can really build bridges about how we can collaborate earlier for goal concordant care that's really independent of prognosis and really focuses on developing longitudinal relationships so we can follow patients through this very different trajectory for their treatment and their illness. I think one of the big take-home points that we shared with them is that it's much more important, particularly when you're working together with colleagues that you don't know a lot about their diseases and the treatments, is to be curious rather than be right. And being intellectually curious about what these treatments are, how they take care of them, their involvement, being intellectually curious about outcomes and toxicities, and reciprocally being able to learn from them and then teach them about the things that we could bring to pass to provide integrative services around, again, coping, symptom management, and collaboration. That we can't know it all, and so this being a sort of a newer field of care for patients with cancer, that being curious about what's happening will kind of help us to get to know their teams, them to get to know us, to like each other in the work that we do, and then finally be able to trust each other to provide collaborative care.
So in terms of specific resources, there will be an article coming out hopefully in the next few months in the Top 10 Tips series in the Journal of Palliative Medicine that Jason and I and a whole actually group of people are working on actively, that we hope will be a very useful resource. Basically the top 10 tips for palliative care clinicians who are facing a patient and family who are dealing with a hematologic malignancy. So that may be one useful resource for folks to go to. And then there also will be a chapter in the Oxford Textbook of Palliative Medicine, its new edition that comes out soon, that will be the first ever chapter there about palliative care issues in hematology, which to me is a really great sign that this work is coming of age and people are starting to be called more to see these patients. And that is a wonderful thing. It does, though, bring new challenges, and that's a big part of why we were talking about this and trying to help demystify parts of it for people, because it is not reasonable to expect that a palliative care clinician is going to know and understand all of these diseases and to be able to accurately prognosticate and to know what the therapies are and what those will be like for patients and families. We don't even know that half the time as the treating oncologists, and things evolve so quickly. That's not a reasonable expectation, but hopefully these resources and our presentation will be a good way to get folks up to speed in a basic level where they can then be more effective at integrating palliative care into hematology practice in their local settings.
I think one of the easiest things for clinicians is to find a friendly oncologist who has an interest, particularly who does hematologic malignancies work primarily, and to be curious about the work they do, and to sit down and to learn, actively ask to learn more about treatments, their paradigm and how they think about taking care of patients. It'll probably be interesting to kind of find out from them their perspective of how you might be able to be helpful. One of the frameworks that I give to our consult team is if you kind of hear people talking about the sort of how much time they're spending in the room with a particular family on rounds, and probably the degree of distress that a patient and their family are experiencing is probably directly correlated to how much time the oncologist has to spend in the room. And those would be opportunities to offer up your expertise in communication and coordination of care and coping assistance that would really probably help to bring you into care earlier on to try to help those teams. And oftentimes it's creating those little relationships where you actually help a lot with a few patients that really starts to bring in much more of a relationship that's developed to provide care. So a friendly oncologist is really a great tool.